Hi, y'all. I'm Elizabeth Thiele, and I'm from Massachusetts General Hospital in Boston. And I'd like to thank Warren and Patty and the organizers for including me in this. I think this has been a pretty wicked, powerful day. I mean, it's nice to be part of it. That's the Boston in me. And kind of what we've been asked to talk about is cover two things very dear to me. One is dietary therapy in epilepsy, and then the other is wellness. And kind of, thank you, ma'am. So what is it? It should be this one. The other one. All right. Should we just ask them to do it now? Do you mind going to the first slide? No. Who did that? Did you do that, Patty? I did. Okay. Can you have the first slide? That didn't work. So kind of just for the ease of the flow of the thing, what we decided to flip this. And first I'm going to talk about the concept of wellness in epilepsy, both kind of what I think of it as a meaning and how do we approach it. And then we'll turn to diet as a treatment for epilepsy. First, very quickly talking about the classic ketogenic diet, which probably most of you have at least heard of. And then talking very briefly about the current variations on a theme, including the modified Atkins diet and low glycemic index treatment. And then I'll finish up by saying who, what, when, where, and why regarding dietary therapy in epilepsy. So next slide. So I think it was kind of, this point was driven home this morning in a pretty big way, that in epilepsy, it's really not just the seizures. And I think most of these points were pretty well discussed. The one I would point out that I don't think was that third. Particularly taking care of kids with epilepsy, there's actually a very good literature, and many parents can tell you that if their child has epilepsy, their abilities, both academic and otherwise, are often underestimated by those around them. And so kind of I think and feel pretty strongly, as I think most of you and a lot of people do, that when we treat epilepsy, treating the seizures is really not good enough. So next slide. So therefore, I think and feel pretty strongly that it's crucial to promote this concept of wellness for the individual with epilepsy as well as their family. But the big question is, how do you do that? So next slide. And I think that kind of what we need to do in order to do that is to take care of the whole person, the whole child or the whole adult with epilepsy, as well as their families. As it has been brought up, and you all know, epilepsy affects not just the person with the seizures, but the families around them and others. So we're taking this now pretty seriously at the Mass General, and I thought I'd just tell you some of the things that we've been working on and planning. And we're taking it so seriously that we've now hired a director of wellness, until I can think of a less cheesy term. And that person's charge is to further develop these programs for our kids as well as their families, addressing different aspects of their needs other than just treating the seizures, how to make these programs available for the kids we take care of and their families, how to make them sustainable, and how can we judge outcomes research or determine if these programs are indeed effective in achieving our goal. So one thing we do is promote healthy diet and nutrition, and that's distinct from using diet as a treatment in epilepsy. And then something we've had now for going on 9 years that I'm very proud of, has been wicked effective, is a karate program for children with epilepsy. And we have done outcomes research on this. And we saw that with this program, it improved the self-concept or self-esteem of the children participating in it, and also decreased parental stress and anxiety. We've also had a yoga program for kids with epilepsy, a therapeutic dance program, and we're planning to expand to Zumba, rock climbing, and rowing for different ages of children and as well as their siblings. We also are trying to increase the education of epilepsy for our families as well as those in the lives of our kids. And we've now held annual educational conferences for families living with epilepsy. And we've also had annual conferences, day-long conferences that have been very successful. Last month we had our most recent one and had about 200 educators from all over New England, again, educating the educators about different aspects of epilepsy. And then this past year we had for the first time, which was also fantastic, and we're planning to do annually, a program of taking epilepsy to college for both our kids in college, our kids planning on going to college, as well as their parents. Next slide. Next slide, please. And the other things we've done and are planning to expand, I think, are crucial, are sibling workshops as well as parent workshops in order to help assess and help with the impact of epilepsy on the rest of the family. And we also do things just for fun, but also, again, to support. And we're going to transition soon into dietary therapy, but we now have had for 9 years, which has become an institution at the Mass General as a Halloween party for our kids on dietary therapy and their family. That has become so successful that families call us in the summer to find out when it's going to be in the fall so they can plan their fall around it. We're also planning on starting drum circles. For a Harvard hospital, we're kind of granola. It's kind of interesting. And then I think it'd be interesting if we have time during the conversation to get ideas from you all of things that you think would help kind of address this issue of taking care of the whole individual with epilepsy or things that you've experienced. So next slide. So this is a segue into to talk about dietary therapy. And this is just a picture of one of my kids who has highly refractory epilepsy. This is actually at the Halloween party, even though he is in a Red Sox shirt. That was his costume that year. And he has been on dietary therapy. So next slide. So kind of then addressing quickly the concept of dietary therapy in epilepsy. The first point I'd like to make, I think, is a very important point, and that this is not a new idea. The idea that diet could treat epilepsy is thousands of years old, actually, and Hippocrates in 400 BC wrote in his very famous medical text, Sacred Disease, that changing diet was essential in treating epilepsy. Then the first diet we're going to talk about is the classic ketogenic diet, which, as you all know, was developed in this country in the 1920s. And it is a high-fat, low-carbohydrate diet designed to mimic starvation while maintaining adequate nutrition. And this basically just shows graphically what the ketogenic diet is. The typical American diet is on the right, and as you can see, Americans like carbohydrates a lot, as does most of the world. And then on the left is the ketogenic diet. So you can see the majority of calories in the diet, which does maintain adequate nutrition for people on it, consists mainly of fats. Next slide. So the next take-home point about dietary therapy in epilepsy is it's wicked effective. So up to 1/3 of kids who go on dietary therapy become seizure-free, and those kids have typically been on 4 to 6 anticonvulsant drugs prior to going on diet, and up to 2/3 of kids have a greater than 50% reduction in seizures. And that data is based on numerous studies, both retrospective as well as a prospective study, over the past 90 years. So in addition to a lot of experience, the outcomes of dietary therapy has been incredibly consistent over 90 years. The other thing we've learned with use of the diet is it does work for all seizure types and most etiologies, which I think is an important point because we'll often see families who are told, oh, no, it wasn't for my type of seizure, or the reason my child has epilepsy isn't amenable to dietary therapy. And then the other thing that we're all very excited about in the dietary community is it is getting increasing interest both in the clinical and scientific community for epilepsy. And one way you can assess that is to see how many times or how often things are cited or talked about in the medical literature. So there have been over 900 articles on dietary therapy since around the 1960s. And interestingly, importantly, over 850 of them have been in the past 15 years. So an increasing amount of interest in the diet, both its clinical use and how it works. And I think that stems from the fact that I think it probably is one of the most effective treatments we have for epilepsy. So it's very important to figure out how it works, and importantly, could it be put into a pill form? But the next take-home point about the diet, which anyone in this room who has tried it knows, it is anything but easy. It's very difficult, very restrictive for the child, so no birthday cake, no French fries, no McDonald's. And it's also very difficult for the family because implementing the classic ketogenic diet means they follow specific meal plans, requiring weighing out of all the foods, so that's quite difficult. Not only laborious for a family that's busy and doing things, but also if a family wants to go out to a restaurant, that's difficult, and if a family wants to go on vacation, that's difficult. So I think the big question is, could dietary therapy be easier and still be effective? So next slide, and I'll just mention these. Beth is going to kind of talk about the distinctions of these diets a little bit more detail. But currently there are 2 variations on a theme of the classic ketogenic diet. The modified Atkins diet, which was developed at Johns Hopkins Hospital over the past 10 years, and then low glycemic index treatment, or LGIT, which we developed at the Mass General Hospital over the past 8 or 9 years. And both of these diets are now used kind of nationally and internationally. And so far, it seems like both diets are very effective. Next slide. So then kind of turning to the who, what, when, where, and why of dietary therapy. I think the who is shown proven efficacy in all seizure types. And there is an evolving role of dietary therapy in the treatment of infantile spasms, which if y'all are familiar with infantile spasms, it's considered a catastrophic epilepsy of childhood, and currently we have very few effective medications. Also, as I said, proven efficacy for many etiologies of seizures. In fact, for some types of seizures, it's beginning to be considered a first-line treatment, including myoclonic atonic epilepsy, or what used to be called Deuce syndrome, It can be very effective in Dravet syndrome, and then also it can be very effective with glucose transporter deficiency in tuberous sclerosis complex, and as well as Angelman syndrome. There is definitely proven efficacy over the last 90 years of dietary therapy in children, increasing data in babies. But I think the big question is, what about adults? And we can talk about this during the question and answer period. There is some published data on the classic ketogenic diet in adults. And now both modified Atkins and LGIT are being used by adults. And we have a prospective study looking at LGIT in adults. So next. Then the what, where, and when. So what? There is a classic ketogenic diet we quickly discussed, as well as these variations. So all three are being used. There is no comparative data looking at one diet compared to the other. And the question is, do we need to have that? Where, if you wanted to consider diet, there's a growing number of centers offering dietary therapy, and the Charlie Foundation maintains a database of centers. And when? And dietary therapy traditionally has been used in the setting of refractory epilepsy, often highly refractory epilepsy. And I think a lot of people are now thinking, should it be used earlier, particularly in the forms of epilepsy we talked about? And should it be considered in some cases as either first-line or second-line treatment? And if so, when? And then finally, why? Next slide. Why should dietary therapy be considered? I think arguably it's one of the most, if not the most effective treatment we have for refractory epilepsy, and remains so even with the increasing number of new anticonvulsant medications. So I feel, granted I'm a self-proclaimed zealot for dietary therapy, but I think that all of these diets play a very important role in our armamentarium for the treatment of seizures. Thank you.
Boy, right on time, too. Thank you, Elizabeth. And now from the Charlie Foundation is Beth Zupec-Kania. And I have to say that the Charlie Foundation has been very instrumental in getting the interest in the diet back again after many years.
So I don't have any slides, I'll be brief because I think slides would be more helpful to go into detail. So I'm going to be very brief about distinguishing between the therapies and then allow you to ask questions because I think that'll be more helpful to you. First of all, I'm a clinical dietitian. That's my background. But I have been working for the past 18 years with people that have epilepsy, primarily children. But I've also worked with adults. And I also work with these therapies for conditions other than epilepsy. I've worked with Alzheimer's and a certain type of brain tumor and with children that have autism. So I have heard snippets throughout the last couple days of, let's see what other therapies we can learn from. And I'll tell you, the reason I'm in this field is because it fascinates me to see how a diet can affect someone's brain in such a short period of time. It's really amazing. And yes, it doesn't work for everyone, but if we can help 50% of comers to this therapy, that's a pretty big deal. So let me distinguish the diets that Elizabeth mentioned. So classic keto is the one that we all think about. That's the one that was designed in the early 1920s. It's a diet that is weighed on a scale. It's pretty structured, seems to work great for children, right? Because there's always a caregiver to weigh out foods. So we like using it for young children particularly. As children get older and they're out on their own, it does become more difficult. Low glycemic index is a structured diet as well, but you don't need a scale. It's not started up in the hospital as the classic diet is. And it really teaches you how to eat a balanced diet. And in addition to helping epilepsy, it teaches people how to eat right. So those are a few of the elements of the low glycemic index diet, LGIT for short. Then the modified Atkins diet is another of the newer diet therapies that was also designed for the older group, adolescents and adults. And this is probably the most loose of guidelines of the three types of diets because you're really only given a restriction in carbohydrate. And I think I have to mention that although it sounds easy, I have found a lot of people, easy is relative because it's easy for me to tell them the diet because they have to do all the work. right? And some people find that difficult. Some people would rather find something more structured. So you can see we kind of try and fit the diet to someone's needs and not just say, well, let's try this diet first. If this doesn't work, we'll try that diet. There really can be a selective process. And finally, I want to mention that there's this MCT oil diet, which is the first diet that I was trained on. It's also very old therapy, and it allows a pretty liberal intake of carbohydrate. It is a diet that you also weigh on a scale, but you drink this very special oil called MCT oil, and that allows you to take in a lot more carbohydrate. So I've used that diet as well, and that is one that I recommend for adults or vegetarians or athletes, people that really just need more carb in their diet. So that is the, the 2-minute spiel on distinguishing the diets, and I think we can take questions from here.
Thank you.
So that's a good question. MCT means medium chain triglycerides. And so to help you understand that a bit, most of the fat that we have in our diet, butter and oils, olive oil, vegetable oil, are long chain fats. So it's a long chain. It's actually a polymer, a long chain of carbons. And medium chain is about 2/3 the size. So in our country, we get our medium chain fats mostly from coconut oil and palm fruit oil or palm kernel oil.
Okay, thank you, Beth and Elizabeth. And now we have quite a bit of time for questions. So I'll start here and then Lisa. Yes.
Yeah. I have had both ADD and epilepsy since I was a kid, diagnosed about the same time. I've lost jobs as an adult because of ADD, not because of epilepsy. So I'm curious to know where the dietary and wellness interface may be between those things. And in terms of additional programs at the hospital, I want to strongly suggest bicycling, because road racing and road riding, when you're focusing on making perfect circles, can be very meditative and helpful with your breathing and rhythms that way. And also a cappella singing, because music builds the connections between the two hemispheres, and everybody has an axe. Everybody's got vocal cords, and everybody can sing. I go to a church here in San Francisco where we dance at every service, and all the music is a cappella, and everybody gets to be a better singer coming to church in that church. So those are two things I want to highly commend to you as future programs. Obviously, if you're going to put kids on bikes on the road, they won't need to be seizure-free during that time. However, I'm now a bike safety instructor with League of American Bicyclists. I've been independent without having to drive a car all the way through college, and that is part of what kids are going to need, is that sense of self-worth and independence that I got starting at age 11, delivering prescriptions on a 3-speed in Redwood City. So I want to commend those two things to you as adding to your program.
Thank you. Elizabeth?
Thank you very much. Yeah, I think all of these things, I think the nice thing about the karate program and some of these other activities like riding bicycles together, we were talking, sometimes it's tough for our kids with seizures to play at team sports, oftentimes because of attention difficulties, ability to do it. So kind of things like karate where you do in parallel, or bicycling where you do in parallel are fantastic. I think singing is also fantastic. I have participated in a lot of these programs with our kids, and I don't think they'd appreciate me singing with them. But and kind of about the ADD and epilepsy, that's a really interesting question. And many years ago it came out, and Beth can also address this being a dietitian, that sugar did not have an effect on attention and activity levels of children. I knew in my own children that was not true. And kind of what happens on low glycemic as well as on ketogenic diet is the blood glucose level is rock stable throughout the day. And I actually think that if you ask our families, and we've looked at some behavioral paradigms, not specifically ADD, families overall will say that kids' behaviors on these diets are much better modulated, and I do think they often are much more attentive. So I do think it could be helpful.
Okay. Lisa?
Thank you so much for that info. It's great. I have 2 questions. One is if someone was interested in starting one of those diets, the modified Atkins or the low glycemic, how would average Jill go about starting? That's question number one.
I knew this question would come up, so I thought of an analogy. So it's like this. If I said to you, okay, I'm going to send you to the pool and climb up to the high dive and jump off into the diving well, what would you say to me?
You're crazy.
Okay. Don't do the diet by yourself. That's the point I'm making here. This needs to be medically supervised. So having said that, I'm telling you, you really need to go to a center that provides this therapy, and many people have to travel to go to centers. But I also want to say there are things that you can do that aren't the full-blown metabolic ketogenic diets that I'm talking about that can probably and may improve seizure control. And one thing is just to eat a better diet. And there are many resources for that. I had asked permission to mention the name of a woman that's in this room that I met earlier today. Adrienne, do you want to stand up? Adrienne is a nutritionist in the Bay Area, and she only works with people that have epilepsy. She has an epilepsy wellness consulting service. And I said, I'm so glad to meet you because I have probably going to get questions of people that want to talk to somebody. And diet, it's hard to follow a diet. And I live with people that I'm very close to that tell me, I see you every day and you remind me to do this and you do that. And it's still hard for me to follow a diet. But if you work with a professional, you're going to take more ownership and you're going to go back to them and you'll be much more successful. So I encourage you, if you're thinking about changing your diet, to seek help from somebody that has an expertise in nutrition, and it doesn't have to be our level of care at these epilepsy centers.
Well, this brings me to my second question, which is about 6 months ago, I ended a doctor-supervised diet that had very few carbs in it. It's very regulated, weighed diet. My seizure activity increased. I am just beginning to realize after I started transitioning back onto more normal foods. Have you ever seen that? Is that documented? It was a pretty low glycemic
That
diet.
after going back to a more regular American diet, your seizures increased?
Well, and I never went back to a totally American diet.
No, we definitely see that. It's one of the things that kind of, I think, leads credence to the whole ketogenic diet concept is if kids are on the classic ketogenic diet and if they're exposed to exogenous carbohydrates for any reason, they'll often have increased seizures. And we've even discussed the low glycemic index diet treatment with some of our families. They'll just try to take out some refined sugars, short of going whole hog on the diet, and they'll see a decrease in their kids' seizures. So that doesn't surprise me at all, and that would actually make me wonder optimistically if dietary therapy could be helpful for you.
Yeah, I think we're going here in the middle.
I have
Can you push
two
the
questions.
microphone? There you go.
Vertically challenged. I have two questions. The first is that it concerns me that most of the conversation in this particular sector is directed at children. And while I have a child, she's 45 years old, and I still consider her my kid, but she doesn't fit into this part of the discussion. But I did inadvertently hear the program yesterday on KQED, and I believe Dr. Schechter referred to,
Was
he the doctor?
Dr. Lowenstein. Dan, are you in the room? I saw him before.
Lowenstein's
Yeah, he's
Well,
over here.
I'm not certain that it was you, but someone did refer to the difficulty of the ketogenic diet. And as an alternative, the South Beach diet. Is that the low glycemic diet that you're speaking of?
So to answer your first question, I apologize for part of that. I'm a child neurologist, a pediatric epileptologist, and I tried to keep saying individual if I slipped and said kids. Most of the published experience with dietary therapy is in children because, as Beth said, it's easier. It's easier to control what your child's eating. Both modified Atkins and low glycemic are now being used by adults and in adults, and we've had really good efficacy in adults. In fact, we were approached by a epilepsy group in the United Kingdom a couple years ago of women with epilepsy who were very interested in the concept of using low glycemic index treatment during pregnancy. And we think that could possibly be feasible because it's not so different from diets that diabetic women are on. But we're trying to get evidence and data of safety, efficacy, tolerability, et cetera, in adults prior to proceeding and looking at a trial in pregnancy, making sure first it works and it's safe. So I think both these diets can work in adults, and both modified Atkins and low glycemic are being used. We have also put adults on classic ketogenic diet and find that adults just have a much tougher time with the restrictions. Low glycemic index treatment is kind of like South Beach, but not exactly like South Beach. So South Beach also limits carbohydrates pretty significantly. The difference is we also limit the type of carbohydrate probably a little bit more significantly than South Beach does.
But the low glycemic is not structured like South Beach.
So the South Beach diet is structured because it's lots of recipes that you can follow, right?
Right.
So the low glycemic is not structured in that way.
Yeah.
But kind of the dietitian goes over and educates the person doing or the parents of the person doing it as to what the glycemic index of carbohydrates means and how to construct the diet. So we do limit carbs on low glycemic, but we limit them to 40 to 60 grams per day, whereas on the classic ketogenic diet, it's about 10 grams per day.
Yeah. Okay, thank you very much.
Thank you. Over here.
Thank you. I have a comment and a question. This is for parents. A nutritionist taught me when my son was very young, when he was 4, to tell him to check in with his body. So when he would eat something questionable, like a milkshake or something, I'd say, check in with your body. And he actually ended up giving up a lot of lousy foods. So he makes better food choices now. He's 15 and has a pretty good diet. And, there's also a lot of online support for any of these diets, I think. So, if you, as they said, you, of course, would want to go with a professional, but then you can probably find other parents or other adults who are doing these diets and can help you with recipes and things. I have a question. Are you familiar with the specific carbohydrate diet, and do you know if that has any effect on seizures?
So I think the element of the diets that we use for epilepsy, the fat is such an important component. It's not just about carbs. I think people get focused on carbohydrates, but it's really the fat, because fat breaks down into ketones, and we know somehow those ketones, or we believe those ketones, are partly responsible for the seizure control. So the specific carbohydrate diet is a good idea when you're thinking about, well, how do I learn to get rid of bad carbs versus good carbs? But it doesn't really, it doesn't fit the description of the epilepsy therapy diets that we're talking about, so it's part way there.
Thank you.
We only have time for one more question, I'm afraid. And
actually, that almost goes into mine. Thank you, first of all, for mentioning me in the Bay Area. The question is the ketone thing. When you're talking about these different wellness programs that you have that kind of address confidence and well-being, what do you think the role of diet and wellness combined is in has an effect on like whole body inflammation or different biomarkers of stress? It's kind of what your thoughts are on that. Thank you.
I think that's a really, really good question, and I think that probably wellness would help all of us, because I think this whole concept of wellness kind of, to me, is a more serene state without the anxiety, stresses, and everything, and we all know that anxiety, stress, and other things kind of wear us down, and kind of there's, evolving, I think there will be even more evolving data over the coming years of the role of all those things and the inflammatory system, the immune system, et cetera. But it makes sense to me, even if there's not hardcore scientific data, that the sense of wellness implies a real sense of wellness. I don't think it's an arbitrary term. I think your total body wellness. And I do think that the diet, we find that on the diets, in addition to seizures being better controlled, we often talk that our kids on the diets are often our healthiest kids we're taking care of. And so I think in my mind, part of it is that maybe the typical American diet, especially one that's really high in carbs, especially refined sugars, et cetera, you kind of eat food like that, your blood glucose goes really high, your pancreas secretes insulin, your blood glucose goes down, so it's all these metabolic shifts during the day. And so on these diets, blood glucose is really, really stabilized. And so I think that also kind of reduces overall stress to the body.
I think there's also quite a bit of animal research also going on about this. So hopefully in the future there'll be better understanding even through all the research projects that are going on.
No, and that's actually one of the really exciting areas that kind of people who are zealots for dietary therapy for epilepsy are even more excited about is there is increasing basic science interest and work going on about this. And as Beth said earlier, there's also expanding indications and uses of diets like this in other neurologic disorders and cancer. So I think in the next 5 or 10 years, dietary therapy is going to become even more important aspect, not only in epilepsy, but also Alzheimer's, Parkinson's, types of cancer, as well as other disorders.
Okay, thank you. Oh, did you want to
Could I just finally say I wanted to touch on what a woman over here had just said about resources. There are online resources. The Charlie Foundation has a website for which includes a community forum. So you can, if you just want to go in there and peruse through what people talk about, you can do that. But if you want to comment, you register and you can make comments. And I moderate it, so I keep it clean. But there's also Yahoo groups for low glycemic index, I think, maybe for you. I'm not sure about low glycemic index, but for certain modified Atkins. So there's online resources just to kind of look into, what's going on in these communities and how do people live with this.
Okay, so I think we should thank Elizabeth and Beth for this.